Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to use an article from the International Journal of Osteopathic Medicine, as I often do, to allow me to talk specifically about the benefits of the barrier concept, aka in my heuristic approach, don't make them say ouch, aka avoid protective responses from the patient. And also, I'll be able to point to an anecdote in my own clinical experience that highlights why this becomes important. So, the article, as of when I'm looking at this, is in the articles in press portion. And the title of the article is Shaft Femoral Fracture Secondary to Osteopathic Manipulation Case Report and Medico-Legal Implication. Please excuse me for clearing my throat. I'm going to read the abstract and then I'll add commentary. So with the abstract, to read, background. People increasingly look for osteopathic practitioners due to musculoskeletal conditions, particularly for low back pain. Serious complications such as femur fractures are rare and often depend on bone fragility due to osteoporosis or neoplastic involvement. So a patient may present and not know that they are osteoporotic or that they have neoplastic involvement, aka the growth of a tumor. And so they may not know, and you may not know. From the external environment of observation, you'd have an exceptionally hard time identifying this. This is why imaging becomes exceptionally important. And when I speak about my clinical experience, it will become a little bit more obvious. To read again, case report. We present a 43-year-old woman who suffered a femur fracture following osteopath manipulation at the lumbar and right thigh for low back pain of recent onset. The osteopath did not document informed consent, disclosure, and personal clinical history collection. After hospitalization, the patient underwent synthesis with femoral nailing. Further investigation found secondary pelvic and spinal bones lesions of a breast cancer 12 years after the treatment and out of follow-up. One of the things I just want to make quick commentary on as I'm reading this and the way that my brain ends up processing it, it's highly likely that this is either translated from Italian or the authors who are Italian may be translating in a way that for a native English speaker just ends up being a little bit off rhythm. The information is clear and it's fine. It's just as you consume it, there might be something that messes with you a little bit, but the information is clear and fine. Discussion to read again. In Italy, the osteopath is a health professional aimed at maintaining well-being through external manipulation. The osteopath must then document in writing the informative process concerning the osteopathic method and the related risks, as well as subject's consent. Meanwhile, a preliminary pathological history collection and objective examination must be performed to exclude pathological conditions, otherwise to be referred to a physician for further assessment and management. So I'll make quick commentary here. The ability to differentially diagnose some possible pathologies is especially hard, especially when they would require visualization of things deep to the skin. You can get a strong sense that you have concern that should be checked deep to skin with visualization, aka radiology or some kind of imaging that maybe isn't radiology. But you're not going to do a good job detecting a neoplastic tumor. Again, I'll make commentary on that when I talk about my specific clinical experience. Something will be funny, but you probably can't figure it out. You probably actually can't differentially diagnose it. So you should be cautious and understand that it's highly likely in everybody that something's going on that you can't detect. So if anything seems off, you should refer out. To read again, conclusions. The osteopath, who usually works as a self-insured freelance professional, is called to inform the patient of the risks associated with manipulation and of alternative options, and to plan the care pathway after proper clinical assessment of the subject by anticipating the possibility of further investigation by a physician. So yeah, the refer out, more or less. Now, the thing that I want to make general commentary on, because I only have the abstract, I don't have the full article available to me. The fact that the right femur was fractured and there was, I believe, some fracture in the pelvis, if I read that properly. Let me look again. Femur fracture. Yeah, femur fracture. So the femur fracture, yeah, just the femur fracture at the lumbar and right thigh. Osteopath manipulation at the lumbar and right thigh for low back pain. Okay, so if you're generating enough force to fracture a femur because you're trying to use the leg to get to the low back, if that's your aim, it is entirely likely that you're doing something that many would find a chiropractor would do. I do not know this to be the case. This is a prediction based on the report in the abstract, so I could easily be wrong. But what it sounds like is the patient was in lateral recumbent. The practitioner was probably pulling the thigh forward, twisting the back backwards. So essentially, if their right side was up, they were probably pushing the right torso backwards, letting likely the right thigh start to come forwards. They probably either used their hand or put their knee on the right femur and did something HVLA-ish, fast and forceful. That would be my prediction, superficially, knowing that I could easily be wrong based on the information here. The fact that they had cancer, it's entirely possible. So I don't know if it was osteoporotic or the patient was osteoporotic or had a neoplasm. Did they? Yeah. It doesn't say it there, so I'm not sure. But there's obvious bone fragility from something. There is cancer in other ways in other locations. Okay, so deep to skin, there can be something easily happening. This is one example of such an issue. There can be stuff that's happening that the practitioner doesn't know about and the patient doesn't know about, and neither one of them can figure out without some form of further investigation that the osteopathic practitioner just can't do. Okay, if you poke around, you will find, I think it was around 2016 or 2017, there's a case out of Quebec where an osteopathic practitioner was working on a patient. The patient had major vascular issues with their arm, and the arm ended up getting amputated. I believe the osteopathic practitioner was sued but found not at fault. I may be wrong on this. And part of it is because they were attempting to send out, but the patient didn't go. So the patient's arm was essentially gray. It was avascular, and it did get amputated. So there's some details that I'm definitely missing. I think the osteopathic practitioner was found not at fault. In that circumstance, you can find that. If you poke around in chiropractic literature, say with thrust to the thoracic region, breaking ribs and breaking transverse processes is not, say, chronic, but it's not weird. So HVLA has some obvious dangers, especially if there's anything going on with the bones in the region that you're going to have contact with, and thrust generally. So because there could be something going on, whether it's a soft tissue or a bony tissue, that you can't see, the patient can't tell, and you can't figure out, if you go fast, you could make it go boom. If you go smooth and slow, if anything's building, the patient has time to tell you, and you have time to detect protective responses. AKA, use the barrier concept, and you're far less likely to go fast enough that you can't stop and the patient can't tell you to stop if something's building. So that something that's building is told to you either by the patient directly verbalizing it or some form of abrupt response in response to your movement. So they jump, they yelp, they make a big face, they pull away, something like that. You have that option if you go smooth and slow enough, but not too slow that it's uncomfortable for the patient. If you go fast, then there's something hanging out. You're just going to break it immediately. And aside from the pain, neither of you may know. I mean, under some circumstances, you'll know. So what this then allows me to do is comment on a clinical experience that I had. There was a patient that came in, was carrying drywall, heard a very large pop in their knee, and was concerned about it having a hard time walking. I assessed them, and the knee seemed stable, and there was other large restrictions that seemed meaningful to work on. And the restrictions changed, so we got them moving better, and they would return for treatment. We were treating fairly frequently, and all things were mobilizing appropriately, but the pain report that the patient continued to provide was not relating properly to the change in motion. And I kept saying, you need to see the doctor, you need to see the doctor. The time that this happened was during lockdowns. It was not really during lockdowns. It was during COVID. So the ability to approach medical care was different. It was much harder. The patient was concerned with the state of the healthcare system in Ontario and didn't like it. So they didn't want to go. They didn't want to go. And I kept saying, you got to go. This isn't making any sense. We get you moving better. You still feel exactly the same. Something else is going on. I don't know what else is going on, but you need an image. And they stopped coming for treatment. So I didn't necessarily have much information. A few months later, I ended up being informed that they had surgery for a Ewing sarcoma, so a neoplastic growth on the femur. So essentially, a large portion of the femur got cut out. They got a titanium femur because there was cancer. Now, I didn't know that there was cancer. I didn't predict that there was cancer. I just knew that based on how they were responding to treatment and how they were reporting their internal state and their internal sensation, these things weren't matching up. There was a problem. I couldn't tell what it was, but I could tell that it wasn't adding up and that they needed other medical care. Now, sometime considerably later than that, they came back for treatment because something else was going on. So I knew that they'd gone through the surgical repair of the Ewing sarcoma. And I said, I'm really happy that a bunch of people were in your ear telling you that you should go get it checked out. You got it checked out and you had successful treatment. And the response was that I happened to be the only one telling them that they should get it checked out. So it was an interesting thing for me because using the barrier concept and acknowledging that I can't tell what's internal to the skin in a very clear way, but I can tell when things aren't adding up. I can tell when they're moving better and their report of sensation isn't changing in a consistent way, that there's something else going on. They need further investigation. So luckily, they were able to get care at an appropriate point such that they're still alive, they're thriving, doing quite well, but they happen to have a titanium femur now. So the case study in the International Journal of Osteopathic Medicine allows us to see that it's possible to fracture things because you have an idea that if somebody has back pain, you should do something quite forceful and quite fast by pushing on their femur in order to treat their low back. That is a normal method in chiropractic, in osteopathy around the world, but it carries inherent danger. It's only going to let you know that it's dangerous when you meet the right set of circumstances. So you're always committing an error when you do that. You just usually can't detect what the error is because often it's quote unquote successful. The person tells you about change sensation, but you don't know that when you meet the right set of circumstances, you're literally going to break their femur, right? That should ideally be a warning that big moves that have a lot of force in them are dangerous no matter how well they go. No matter how well an HVLA goes, it's dangerous. And very, very dangerous, even if it works well sometimes. So HVLA to the neck, you'll definitely have people who are ready to have a stroke. You'll do the HVLA and they'll have a stroke, right? It will happen. It is documented. It doesn't happen often, but it is a direct relationship. It's brewing. It's ready to go. Arteries are weakened. Vertebral arteries are weakened. You crack their neck and boom, they're having a stroke. So being more subtle has major benefit. And this case study and my personal clinical experience points in that general direction. If you think there's big moves, there's fancy moves that do this thing or fix this thing, and that's what you operate under, then you're making an error at all times that you can only detect when it gets bad. Whereas if you're a little bit more subtle, you do a good assessment approach, and you purposely try to avoid protective responses by moving at a certain pace and moving at medium forces and maybe tuning it up when it's okay and tuning it down when they do start to get tight, you're going to avoid most of this. So your safety valve is patient active testing so that you know that they can move it and they will move it a certain degree comfortably, as well as the barrier concept. The barrier concept is going to keep the patient and the practitioner safe consistently if you use it appropriately and you acknowledge that there's a huge amount of stuff that could be going on deep to the skin that you can't properly detect. So thank you for listening this far. Hopefully that helped you and we'll talk again soon.